the Synthetic Drug Coalition Subworking Group number 2.1. This is on prevention. Beginning this month of November through February, we're going to be looking at specific initiatives available to us through international organization partners primarily. We will also explore new activities or policies that we can initiate together. In January and February, we will have the full menu of activities available for review, and we will invite all of you as participants in the coalition to express your interest to the international organizations who are managing the respective initiatives. Some other administrative announcements. Please update your screen name so it lists your name, organization, and country. That will help be a bit more consistent in the names. Also, we are very close to launching the coalition website. We've been announcing it for some time. In the next few days, we'll be sending out an email sharing the URL so that you can all see that website. And we'll be doing a lot of our coalition work between the different months on the website itself. So we'll be able to interact and it'll gain more functionality as the months go on. Additionally, we want to thank you for your feedback regarding the number of calendar invites. We recognize that we have been sending many calendar invites to participants. So to simplify things for future meetings, we're going to send one calendar invite for the entire block of 3 hours for the 3.1 to 3.3 meetings, and one entire block of 4-hour meetings for the 1.1 through 2.2 meetings. So if you've signed up for working groups on both sides, you'll be receiving those blocks both for the East and West group, but it will reduce the number of individual hour blocks. Just remember that if you are part of the 3.1 group and you have a 3-hour block, it's the first hour of the 3-hour block. We are also seeking to continue to increase coalition participation to include stakeholders from all target audiences of synthetic drug issues. So please continue to share the coalition registration links with your colleagues so we can make sure that all stakeholders have a seat at the table. For prevention, we're talking about ministries of education and social development and so many other areas. Now, I'd like to turn it over to the co-chairs for today's meeting so they can call on presenters, share thoughts, and moderate the discussion. And so the co-chairs for 3.1, we have Carolina Bruce from Chile and Inga Dora Sigfúsdóttir from Iceland. Over to the co-chairs. Thank you so much. That's all from me.
Thank you so much, Brian. Thanks for this very clear introduction and reorganization of how we get all these emails. It would be nice to have just one and know that the first one is ours. So yeah. So shall we just not start? And the first person on our agenda is Wadih. And I think he's a person that we all know. So over to you, Wadih.
Thank you very much, Inga Dora. Thank you also, Brian. I'm trying to project my slides in the meantime. Hopefully they are showing up clearly. So my name is Wadih Maalouf. As Inga Dora mentioned, I coordinate the drug prevention program within the prevention, treatment, and rehabilitation section of UNODC. And in the context of the time restrictions that I have, I just want to contextualize what I'm going to present first so that things are organized. I'm going to present a new package that has been introduced that hopefully will be a core component that will help many other initiatives working on prevention nationally. And that will be the review of the prevention system. And another component in the same presentation in the 10 minutes that I have is an actual initiative that we are inviting United States to champion and be part of, which is CHAMPS. I'll talk about them gradually. So to start with the review of the prevention system, the first component, what it is, we know for a fact that when it comes to implementing effective systems of prevention, to have an effective coordination of different activities, a core ingredient is adding several evidence-based programs and policies in place covering different age groups, covering different levels of risks and beyond. But we know for a fact if we really want an effective response, that's not enough. adding more and more interventions that cover different ages and different risk groups also requires a supportive system, kind of an umbrella of a mechanism that embraces these policies and put them in place, and these interventions that actually can amplify or actually dilute the effect of these evidence-based intervention. So mapping out not only the interventions, but also this delivery system of these intervention is a key component for having a system that's in place that's effective. And this is exactly why in the prevention standard under the third chapter, the prevention standard, for those who don't know, is the UNODC WHO International Standards on Drug Use Prevention. There's a specific chapter dedicated to understanding the value of what is a system of prevention beyond just intervention, how things cooperate and collaborate together in order to have a system now. And this is where, in terms, there was a lack of a tool to actually, even though I'm going to use the word in a different way, systematize the way prevention intervention are being mapped out at the local level, meaning at the national level, and being mapped out together in terms of how to move from where we are to another level and how to bring them together, not only at the level of intervention, but a level of terms of how the umbrella that is embracing these interventions is functioning together. And this is where the review of the prevention system came in place. In a way, this is a way of assessing, mapping out all the different sort of intervention that are covered under the prevention response, prevention of drug use in these circumstances that we're discussing, and mapping them out and arbitrating their content against what the prevention standards, the UNODC WHO prevention standard mentions, in the sense of where are they in terms of the evidence that is portrayed in the standard, whether they are evidence-based packages in terms of design and application documented at the local level as evidence-based packages, whether they are imported evidence-based packages adapted to the local context, but not necessarily evaluated in the local context where they are implemented, whether they are evidence-informed, meaning that they have been designed locally, but not necessarily tested, but they have the qualification of what makes an effective intervention, or whether they are far from the intervention standards, whether they are supportive services. So they map out all the different services, and this is where you see the color coding that you have in this slide, whether it's on the red side, on the yellow side, weakly informed, strongly evidence-informed, or evidence-based strategy, or supportive services. So this can be mapped out for every intervention. But that's not where it ends up in terms of a decision-making processes tree. But also, these interventions can be further against another matrix that maps out these services with their color codes across different ages of development. And within these ages of development, whether these interventions are at the universal level, at the selective level, meaning that for the population that are higher risk than the normal population, at the indicated level, whether they are interventions that are portraying evidence that is that are for a subpopulation that is symptomatic and need to be an intervention to address it before it escalates into something more. That is the horizontal way of seeing the mapping out of these interventions. But also vertically, you can see in which social setting these interventions are, maybe in the school, in the family, in the media, community, and beyond. So this is another way to flesh out whatever exists at the national level in a way to identify gaps and strength at the same time in terms of intervention, so that we decision making is being done in a way that is informed by arbitrated by the standard and informed by local data that exists at the national level. This program, that is this strategy, which is the review of the prevention system, has been first piloted. Actually, the whole system has been done with the support of Norway, but it was also implemented in Norway. We would have wished that Norway could have joined to actually demonstrate and talk about their experiences, the Ministry of Health in that case, in terms of implementation of the prevention standards. the review of the prevention system. But even in the absence of Norway speaking directly with regard to the content of this document, the presentation itself has 2 web stories reflecting on the experience of the Norway vis-a-vis this document that fleshes out and describes in more details their experience and how it helped their decision-making processes. Between brackets, recognizing as well my colleague Giovanna, who's the chief of section, who has been a key person in terms of working hand in hand with the national authority in Norway and the course group in terms of actually not only collecting the prevention interventions that are there, but also arbitrating manually, intervention by intervention, where these interventions fall within these processes. Now, with this experience generated in Norway, with this new tool of REPS, this has been a tool that for us as UNODC is a strategically important tool that fill an important gap in the prevention basic element moving forward, where national strategies that are developed for a long period of time have been really based on epidemiological studies, but the SWOT analysis when it comes to actually addressing the strength, weakness, opportunity, and available services that are existing nationally have not been arbitrated by a really sort of proper system of evaluating where the interventions are in the spectrum of the response and where the gaps are. Also, it is a tool that really identified, very systematically intervention and responses that previously have not been accounted for as part of the national strategies by moving with the policymakers in the perspective of digging in for interventions that are in line with the prevention strategy, because the policymakers are always fixated on responses that are articulating the word drugs in them and talking about drugs. And this developmental approach where there are other strategies that not necessarily the intervention of the strategy discuss drugs, but are in line with the standards, are mapped out within the system to capitalize on them and the prevention responses. So it orients national plans of action that would inform decision-making processes rather than just guesswork when it comes to the previous SWOT analysis. It also helped them in terms of efficient investment in resources and priority to articulate the national responses, whether I'm going to invest in further scale up of this intervention, reduce the investment of this intervention that's not evidence-based, increase in investment in this supportive intervention, improve on research and development of the third intervention to move forward and allocate my resources that are designed for prevention in an appropriate way. It advocates for streamlining and coordination responses through this mapping of services, but more importantly, through doing this, it advocates for improving the quality of the prevention delivery, a component that is linked with additional tools that would be talked on with other interventions coming up during the day. But that's a way of understanding the value of having the quality of prevention and promote the value of monitoring and evaluation of prevention interventions. A component of this review of the prevention system as well is assessing how the coordination is happening, the level of coordination, the legislation, not only looking at the level of interventions. So this is item number 1 that needed to be presented with regard to a new tool that hopefully member states will benefit from with regards to being a building block to the prevention response. The second component is that initiative that we are putting in place. With this mapping of new tool that's being developed, CHAMPS, which is the Children Amplified Prevention System service, is a modality that UNODC is inviting member states to really have models globally of investing in prevention at large scale through this developmental approach, mapping out the services that they have at different ages of development for different level of risk, with a level of mechanism of bridging the different partners of the response together, and showcasing within a period of 5 years that is demonstrating that a change in the developmental pathway, including, of course, as a priority for the age group that could move to the age of using drugs. We're talking about children, 0 to 18. Then later ages, that prevention of drug use is put in place because of this investment, and at earlier ages, other indicators of that are on the developmental pathway of at the mediating level of prevention, like improve educational attainment, retention in school, improve mental health, reduction in violence against children, and beyond, can be demonstrated to this level of investment. This is the, in a nutshell, how the system is being put in place as a descriptive model, where first it will start with a review of the prevention system, what exists and what needs to be improved, put forward. Parallel, this is the horizontal line. Vertically, there will be, as usual, this evaluation of the epidemiological situation, of the situation that needs to be addressed in terms of priority work, through which the children that we're talking about from 0 to 18 will be allocated through universal, selective, that's in universal in green, selective in yellow, and indicated at the level of the red line, symptomatic children, would receive a minimum amount of packages through different ages of development, brought together. All of these interventions over a period of 5 years put to scale will have model implementation of different. So it's the challenges of doing it in 10 minutes. So this level of intervention, different ages of development, from pregnancy and early infancy, up to 6 years, which is the period before going to school, 6 to 10 years, the early school years, 11 to 14, early adolescent years, and beyond, would all have a minimum set of skills, of packages that are social and emotional skill, or environmental strategies that are in line with the prevention standards, and demonstrating that this level of investment will showcase effectiveness, will showcase cost effectiveness, and will showcase a high return on investment in preventing drug use and beyond, supporting other strategies. So what we're looking for is, at least in different waves, 10 countries per wave over a period of 5 years. And this first wave of countries, we are hoping that will be launched by CND, our Commission on Narcotic Drugs 2024, which is coincidentally will be during the midterm review period of implementation.
Wadih,
Yes.
tenemos el tiempo.
We are on time now.
Yeah.
Your presentation is super interesting.
Yes, exactly. And that's what I want to present. No, thank you, Karina. I was just wrapping up and finishing. That was my last slide. And that's the CHAMPS initiative. And over back to you.
Thank you so much, Dr. Wahid.
Perdón que me toca.
Pardon me, it's my turn. Pardon me. Before we turn to the second briefing, let me put you in context about what we are discussing. We're discussing prevention systems, and we've heard a very interesting presentation on this matter. So we will talk about training to be able to sustain these systems, and you've seen in the chat agenda that we will be sharing a number of experiences of how this has turned out in various parts of the world, and we will have to call upon you to please comply with the time allotted, because we have a most interesting and intense agenda, and we will try to find mechanisms to exchange experiences beyond these talks. Pardon me for the interruption.
So yes, so shall we keep on? I just wanted to apologize because I of course see that there are 139 people attending the meeting. So Dr. Wahid, I told everyone at the start that that we all know you. So I should have given you a chance to introduce yourself, and I apologize for that. So, but up next we have Camila Patino, who is going to inform us and teach us about professionalizing the workforce. So over to you, Camila.
Hola, es un gusto estar con
Hello,
ustedes en este
it is a
espacio.
pleasure to be with you on this space. Getting back to what the UN had told us about before, we need to have prevention systems considering various areas, different programs or strategies according to local needs to implement evidence-based implementation. We have to train the labor force for those who coordinate and implement this. The professionalization of the labor force should consider prevention because it will strengthen the cycle of these programs from the adaptation, um, planning and implementation, follow-up and evaluation, and it helps us implement it in the most cost-effective way by helping us implement local indicators and make decisions based on our policies, based on evidence, and we can also do a better implementation and provide a common language to those who are providing planning and implementation so that we can persuade the decision makers. First step for professionalizing the labor force is to train the coordinators or managers planning prevention so they can include specific resources for strategy planning and implementation, and the managers should be trained to have the appropriate set of skills to do the effective planning and implementation. Based on this support, countries have the necessary organizational capabilities to support and implement these programs based on evidence. What do we have for training the labor force for prevention? The Columbus plan has developed the UPC, which is designed to address professionals who are competent and trained, and they are uh, trained in these issues and UN standards that have been informed by experts and different strategies for development. And it has two series: coordinators and managers. We will speak more about coordinators. Those of implementers will be seen in the next sessions. The objective of the coordinated series is to train professionals by providing knowledge and strengthening the skills of local teams to diagnose, plan, assess these strategies in the various areas of human endeavor. It's aimed at coordinators and managers for prevention, participating in planning, selection, implementation, monitoring of uh, evidence-based interventions. And these coordinators will supervise the specialists that are doing the on-site implementation of the programs. So what are they offering at UPC? An overall view of the role of prevention coordinators, an approach to physiology and pharmacology of psychoactive substances, effects and consequences, the science for these different interventions and strategies based on evidence in almost 20 years of science and preventions, guidance for the application in various areas, families, schools, and the methods to be able to do that and apply them in real contexts. This series have 9 courses. The 3 first are in the cycle of justification and their requirements to take the specialization cycle consisting or based on family, school, the environment, the media, and community. The implementers series seeking to provide skills and competencies to implementers so they will have better training on the various evidence-based elements, and these implementers are sharing various comments and are committed to the delivery of the program. And this series is based on the core course that will provide certain lines of expertise, family, environment, workplace, and the various environmental systems. Another curriculum that we have is the strategies and actions to support the application of demand reduction initiatives and advocacy, which is seeking to find the frontline workers and directors of the programs and to help them understand the program and integrate them to the reduction demand program. What is this capacity building process trying to seek? Basically develop this knowledge, skills, attitudes, and behaviors to be able to change realities. And for this, we have designed an outreach strategy that starts with a strict development of curriculums by international experts with the help of UN panel of experts. And once we have all these materials reviewed and translated, we start providing the training of local trainers who will train national and local trainers to develop replications, and they will always be supported with technical assistance to make it more accurate. With this process, we're seeking to get these professionals to further increase the practices learned at their workplaces and their services so they can improve the quality thereof and get better results of the people who participate in programs or treatments. For this, Columbus Plan has designed training processes according to the needs of the country, and the countries can choose the mode they want, which is custom-made training, and it can be online or in person for trainers or implementers. These courses always have a set of activities for the practical application of contents, and they rely on technical assistance. The technical assistance is provided to ensure accuracy in the transfer of the training contents, and the technical assistance for post-implementation based on evidence to develop implementation action plans. I would like to conclude without highlighting the strengths of universal curriculums. The whole process is based on a process for technical assistance transfer. These are public materials that have been translated to many languages and are implemented in 80 countries. They are updated on a regular basis. They have gone through a very tough review process. And lastly, the professionals taking these courses can move on to certification to become certified addiction processes through ICAP certification exams. And on this note, I conclude. Thank you so much.
Our next presenter comes from Panama, Shesnarda Herrera, and is going to teach us on the psychology of reducing the demand of substances by CONAPRED, or if I am allowed to try out my Spanish, Psicologa de Reduccion de la Demanda de Drogas de la
Drug
CONAPRED.
Reduction Demand Psychologist of CONAPRED.
Is that okay? So, over to you.
Hola, buenas tardes, buenos días a todos.
Hello, everyone. Good morning or afternoon, wherever you are. I'd like to speak to the experience of the Universal Prevention Curriculum in Panama. It involved many challenges, arrangements, and meetings with government and non-government entities, and we started with the training of trainers course in Panama, and we had 21 professionals who are national trainers, and then we replicated it to the coordinators level, and this led us to creating 6 implementation plans, and we always had all the technical advice and assistance from Columbus Plan. So we should like to thank them for all the installed capability there living in Panama, and for always being aware of every single detail of this training. Thank you so much. From the National Anti-Drug Department, the partnership with Plan Colombia, strategic partnership with Colombo Plan for this strategy has been key. Since 2018, we have been carrying forward a plan for the trainer program, and we have also carried out a training course for prevention, and they have graduated from the course with specific plans to address the issues of their communities, which have been developed in support of a new law in Panama, which is the 858, where municipalities and city halls have to implement the treatment and care policies of our department, and we are also advancing towards the replication of these courses. And now all the states with 20 municipalities around the country, with monitoring of the work to replicate Colombo's plan.
Ahí teníamos otra experiencia de trabajo con el plan.
And here is another experience on the implementation of this plan. And now we will hear the testimony from Colombia, so we can look at how this has been implemented in various areas. And we have a video also from Ms. Restrepo from the Department of Health and Social Security from the Pereira state, which is the coffee producing area of Colombia. Let's look at her presentation. Good morning, everyone. I'm Bibiana Restrepo, coordinator of the Mental Health, Living Together and Drugs dimension of the Health Department of Pereira. It is a pleasure for me to share this training experience on UPC, on the coordinators series under the Columbus Plan in the framework of the pilot project we are carrying forward in our province. This has definitely been an opportunity not only for training but also for further strengthening our intersectoral and interagency work. This training process has not only enabled us to strengthen our approaches on drug prevention, but also strengthen our community and institutional plans through the implementation plans that we've been developing. For us, this is a real opportunity for training, and we'd like to thank you for that.
Carolina, if you give me a chance to introduce the next speaker, because that is a colleague of mine, Dr. Viðar Halldórsson. So Viðar and we have been working together in implementing the Icelandic model for some decades now. So I'm going to give the word over to Dr. Halldórsson.
Yes, can you see the slides? So,
yes.
Okay, hello dear friends from all over the world. My name is Viðar Halldórsson. I'm a professor of sociology. I want to use this short presentation to highlight the importance of the social environment, in particular the local community, for the general well-being of individuals and groups. The local community is in particular important for the young people who are learning about who they are, what is meaningful in life, and how they should live their lives. It takes a village to raise a child, says a well-known saying, and bears much truth in it. The community in which people are embedded provides those young people with important guidelines on what is meaningful in society, about the norms and customs of what they should do, how they should behave, and what they should aim to achieve. The local community can further provide its youngsters with opportunities which leads them to positive and enhancing tracks in life. In other words, the social environment works as an invisible force that steers its inhabitants into certain directions rather than others. Like sociologist Georg Simmel phrased the impact of culture on the lives of people, he said, "The culture carries the person in a stream, and one needs hardly to swim for oneself." So I welcome this global and ambitious and important initiative to tackle the growing problems of substance use among kids and adolescents around the world. This global initiative highlights how evidence-based community programs can help to tackle challenges that endanger the well-being of individuals and their communities, such as the increased use of all kinds of substances. Community prevention is the key to tackle the growing problems of substance use, as my introduction suggested. History tells us that it's not sufficient to send simple messages to kids, like just say no to drugs. or to educate young people about the negative and harmful effect of substance use. Such measures do not work to a large extent. What, on the other hand, has shown to work are evidence-based community prevention programs. I have, for instance, been involved in one such program, a program which emerged in Iceland in the 1990s. In the 1990s, Iceland has faced major problems in terms of adolescents, alcohol, and other substance use. At the time, Iceland had, for instance, the highest proportion of adolescents who had been drunk by the use of alcohol in the whole of Europe. However, with the forming of what is now known as the Icelandic prevention model, Iceland managed to reduce its problems of adolescents' alcohol and the use of other substances to a remarkable extent. In recent years, Iceland has had the lowest proportion of adolescents who have been drunk in the whole of Europe. This figure we see here illustrates the declining trends of alcohol use, cannabis use, and smoking in Iceland from 1998 to present. And the declining trends are a result of the efforts of people in the Icelandic communities to make the world a better and healthier place for its kids and adolescents. This remarkable success in preventing kids and adolescents in start to drink alcohol and other substances has been achieved by a widespread coalition between major community stakeholders in Iceland at the local level. It has, for instance, been important to strengthen the communication between schools, all kinds of leisure activities which kids and adolescents partake in, and their parents, of course, that can in return coordinate their actions in terms of how they can organize activities for the young and further communicate effectively to tackle problems which may arise among the young. It has further been highly effective as a prevention measure of youth substance use if parents know and are in contact with their children's parents' friends. Such social ties create communication among parents, a consensus on the rules and guidelines they wish to impose, and thus works as social control of the social environment in which the children's lives are embedded. It has also been highly effective as a prevention measure of youth substance use if kids and adolescents have opportunities to partake in healthy and challenging leisure activities in the local communities, which are guided by adults. Such activities provide young people with important framework in their everyday lives, in which they need to invest and commit to, and which keeps them occupied with something healthy and meaningful rather than something else. Today, the Icelandic prevention model has become a system in its own terms. In other words, it has become mainstream norm, which is embedded into the Icelandic culture and its institutions. The Icelandic prevention model is further being implemented in many parts of the world. We have evidence that the ideology which the Icelandic prevention model rests on can work in other parts as well as it does in Iceland. Fortunately, we have seen a number of such evidence-based community programs aimed to prevent kids and adolescents of using substances with great success. Other noteworthy community coalitions projects are, for instance, Universal Prevention Curriculum, Communities That Care, and Community Anti-Drug Coalitions of America, which you could probably find information on this channel. Such programs serve as a guiding lights of what works in substance use prevention and what does not work. To sum up the key elements of successful prevention programs, such programs rest on three main pillars. They are evidence-based. For us to know where we are going, we have to know where we stand. Far too many policies and prevention efforts have been written and carried out with no or even negative results, since they were not based on understanding and knowledge of the people or issues they were supposed to affect. They were not based on solid research. Secondly, they are community-based. with focus on changing the social circumstances of young people and through that affecting their behavior by creating a healthier culture which our kids are embedded in. And third, they are based on a broad coalition and dialogue, an ongoing dialogue between research, policy, and practice. In other words, it is through the collective minds of society, as I would like to phrase it, where people can build an important social force in their local communities in the shape of social norms, guidelines, opportunities, and activities for the young, which tacitly, through the local culture, influences the attitudes, behavior, and well-being of its local habitants, in particular the whole cohorts of kids and adolescents. Through collaboration at the local level, people can build healthy social environments which influences the lives of kids and adolescents to a surprisingly large extent. The social environment, in other words, works like social magic, as it can steer whole cohorts of young people away from using substances through those social forces and the collaboration of people within the local community. It really takes a village to raise a child. So thank you for your interest in the topic. Thank you for listening to this presentation, and good luck, everybody, in making the world a better, healthier, and a happier place for generations to come. Thank you very much.
Thank you so much, Viðar. Of course, this program has been in my heart for decades, and you described it in a very wonderful way. So, Carolina, can I give you give it over to you so that you can present the next speaker?
Muchas gracias. Interesante cómo hemos ido.
Thank you very much. Everything's been so interesting. We see how we have been navigating through the different systems, but they are all going towards the same goal. How we are preparing ourselves to develop programs centered in the individual with indicators, with enough preparation to be able to transcend and show results. Now we will have a presentation from Community Care, which is one of the programs that were mentioned in the presentation earlier today by Viðar. I'm sorry, I made a mistake. First, we're going to have a CADCA presentation. This is another program from the perspective of how to organize ourselves better. And this is an experience that is going to be shared with us in this presentation. Please. It's a recording.
Hi, I'm Eric Sierra from CADCA, and with me today is Eliane Prados Marcondes from Brazil. And we're going to share with you today a little bit about CADCA's model for community change, which is predicated on two overarching goals. On one hand, increasing collaboration among groups and sectors of a community, and on the other hand, reducing substance use rates among youth and adults over time. The vehicle from which to accomplish this are community coalitions, which are a formal arrangement of collaboration among groups and sectors of a community. And we equip communities with what they need to know and what they need to do to be effective change agents through the three pillars of our model for community change. And for that description, I'm going to hand it over to Eliane, who's from the country of Brazil.
Thank you, Eric. The Association of Community Coalitions in Brazil has regional coordinators due to the size of the country. They are responsible for the development of coalitions in their regions. They are professionals trained by CADCA. The association is an umbrella organization, and it has been CADCA's partner for 14 years. The coalition network has expanded in Brazil in 4 different states, with the largest number of coalitions in the state of São Paulo. The implementation of coalitions in Brazil provides the integration of the 12 sectors in collaboration to achieve the goal of primary prevention. In Brazil, local governments recognize the valuable contribution of community coalitions as a prevention strategies, and universities play an important role in data collection. Pindamonhangaba Coalition is the first coalition implemented in the state of São Paulo, Brazil. The coalition developed its community assessment by collecting data through a research listening to youth aged 11 to 19 from public schools located in 5 different regions of the city. Through this data collected, the evidence showed the highest percentage for alcohol, and second was cannabis. To complement the data, they had monthly listening sessions and also visited 136 businesses. The coalition helped change public policy through the graduation parties ordinance, which states the youth can no longer consume alcohol during graduation parties. After incorporating strategies for 2 years, we saw a significant decrease in alcohol consumption. By 2022, we saw an additional 29% decrease. The coalition took a similar approach with cannabis. We saw drastic decline in use, once in a lifetime and last 30 days. A great outcome for the Association of Communities in Brazil is that since August, we have been having meetings with State of São Paulo Government Secretariat negotiating expansion for 12 new communities in São Paulo. Thank you for your time and your attention.